I'm going to introduce our next two panelists. The first speaker is well known to us at UHN and the Wilson Center. Is Dr. David Wiljer. He is a professor in the Department of Psychiatry and the Institute for Health Policy Management and Evaluation at U of T. He is also a scientist at the Wilson Center, in addition to his many other hats that he wears, including academic director for CPD at the Temerity Faculty of Medicine, the recently past president of, or still currently past president, I guess, recent president of the Society for Academic Continuing Medical Education, and the leaders of the fellows of that organization. I met David probably 2015, and I found out his PhD was in history, which is very interesting because now he does something very, very different. So you probably could ask him about that. But throughout his research, he's focused on how technology and education can intersect with one another and how digital innovation has been impacting the ways clinicians practice, how we prepare clinicians, and impact important values and practices of clinical work, such as compassion and the role that patients and their families play in shaping and influencing their care. His research program has been spearheaded by the lab that he leads, the Digital Compassion Research Lab, which has been exploring the notion of digital compassion and in healthcare improvement and the delivery of compassionate care through the formation and evolution of health professional identity as it relates to digital health. And so we're going to hear more from David about his own empirical work, not commentaries. David hasn't published many commentaries. He's been doing empirical hard work very early before many of us at the interface of technology, human care, and healthcare. Joining David virtually is Dr. Alaa Youssef. Many of you also know Alaa. She was a former fellow at the Wilson Center, when currently she's a postdoctoral fellow in the Department of Radiology at Stanford University School of Medicine. She received her degree in, received her PhD in data science and population health from IMS in 2021. And her current research addresses the ethical considerations in AI development, aiming to promote responsible use of AI in healthcare using mixed methodology. She's investigating end user experience with AI systems. And she's also leading several education programs and policy initiatives, including co-directing the Stanford AMI high school programs, which is preparing the next generation of scholars and healthcare providers for careers that intersect with AI and medicine. So please welcome David to this stage, and then we'll follow that with Alaa.
So thank you so much for the opportunity to speak. I found the last talk a little devastating because apparently being old isn't sufficient, so that's problematic. I was counting on that. But what being old does is it allows me maybe to reflect a little bit. And so I'm going to reflect on maybe the past decade of experience of thinking about AI, recognizing, as Jeff said, that AI has been going on for a long time. Maybe just share a little bit of that journey. I'm going to try to do this talk without saying two phrases, and you can guess at the end which two phrases I'm going to avoid, but you'll see. Really, as Mahan said, I have a PhD in medieval studies, so it's a bit mystery of why I'm even here. But I've had the pleasure of reformulating my career, and today I'm going to actually put the historian hat on a little bit and have some fun with some reflection. So really what you need to take away from this is, what was the question? So really, the lens that I try to take in this work is inspired by work that Brian and others led, which was this notion of where does compassion and technology intersect. And many of you in this room were part of this book. The timing of the publishing was a bit unfortunate, as this other thing happened while it was being published. But for me, it was an opportunity to crystallize a lot of the thinking. And it was like a light bulb went off that the work that I was really interested in could be encapsulated by this notion of digital compassion. And I find this image of the murmuration of the starlings quite inspiring, which is really a mechanism in nature for people to come together and move forward while protecting each other. And I think that's really what this book encapsulates. And so together with Alison Crawford and Julian Strudwick, we had the opportunity to write this chapter. And at the heart of it, what we did was we took a very functional definition of compassion. There are lots of definitions of compassion. This is a very functional one, from recognition to trying to alleviate suffering. And we married it with, I think, a very progressive notion of digital health, which comes out of the great work of Bertalan Mesko, which doesn't emphasize the technology. It emphasizes two things: the relationship that's happening between the patient and the provider, and the democratization of health. And so these were sort of drivers for the way of the lens of looking at the work. We created this honeycomb to create a bit of a classification around what digital compassion might look like. So things like awareness of suffering, how we can do education. And then at the time, we kind of put this box. There's something there with AI, but we're not quite sure what it's going to be. And people kind of went, okay, maybe AI. But I think the story is playing out in a really interesting way. So I'll sort of start this at 2014, even recognizing that there's a long history here. But I think in medical education, this paper by Rachel Elway started to get people into the conversation around what does data mean for us as researchers, as scholars. And just highlights this notion of maybe we need to expand our understanding of scholarly inquiry. And I think that's what we're doing, is having this debate of, do we expand? Is it the same old work? What does that look like? And Rachel started to identify the various components of this, from teaching and learning to research. And I think lays out an important framework that we can continue with today. And then this character, some of you might know, started wandering around various places and asking this question: will your clinician be replaced by a robot? I'm not sure I have the date quite right, but in any case, and at the same time, we had an event, and Brian was sitting at that table over there, and we were trying to tackle this notion of technology, and we did some arts and crafts. But fundamentally, this question encapsulated what we were trying to grapple with at the time, a very early question about identity. And I show these two pictures that have been shown a lot. The top one is very interesting: healthcare with nobody in the room, right? Nobody in the room. And what does that look like? And at the time, that was kind of jarring. And now we're like, okay, that's what we do. Like, that's nothing. And then the bottom picture is how many people here remember pepper and the whole fad of pepper? Pepper has been retired. They don't make pepper anymore. But this picture helped to start the conversation in a lot of clinical contexts of what is the role of AI at the bedside in terms of clinical care. And all the times that I've shown this picture, there are various reactions. Mostly they either fit into, oh, that's interesting, or that's horrifying. And, you know, where are the clinicians and what's happening there? The best comment I got, I think, was a new dad who said, "I've been replaced by a robot." And so this notion of professional identity started to become an important part of this conversation. So has anybody seen this show, Mozart and the Jungle? A couple of people. So this show is about a Colombian composer who comes to New York, and his name is Rodrigo, and he's pretty passionate, and he's in charge now of the orchestra, and he's got this problem. They've run out of money. Anybody heard of this problem? No, it doesn't happen in healthcare. And so this investor comes, and the investor says, okay, I'm going to fund your whole program, but you have to include AI. And we're going to feed all of Mozart into this AI, and you're going to compose with AI. And Rodrigo is not happy about this. This is very disturbing. But he agrees because he wants the money. And at the end of the day, he tries, and the poor robot ends up being torn apart and thrown into the river. Rodrigo storms off and says, "You can take your money back." And I think we've advanced past this conversation, but it's still there very much in healthcare. What about my identity? Who am I? And where do I sit professionally? And at the same time, it's what is the work that we should be doing? And Brian alluded to this already, but, in 2019, Berlin Mesco said, "Hey, I'm a futurist. This is the future." A year later, the future was here, and we had, telehealth chatbots and artificial intelligence. And this doesn't really feel very futuristic, does it? It's what we do. And around 2019, this commentary came out from the Harvard Business Review. How do you build an enabled organization, an AI organization? And I think most organizations are grappling with the central issues. Is it centralized, decentralized? How do you get people to talk to each other? But the fundamental thing that came out of this paper was educate everyone. And I thought to myself, how do you do that? That's confusing, and we don't really have a roadmap. And I think you, Martin, alluded to that in terms of how do we start to think about what education people need. And so we wrote a commentary, because that's what we do. And we asked the question around, what do people need to know? And the reason this was based on a little bit of evidence, but there really wasn't much in the literature at the time in terms of what we should be doing. So we asked this question about how best to prepare healthcare professionals to have the knowledge, skills, and attitudes to harness the power of AI. And we came up with a bunch of categories, and from the conversation, what happened. We came up with a bunch of categories that probably aren't that useful right now. But at the time they were, and they talked about governance and thinking about quality of data and how to interpret that data. And so the timing of when this comes out, I think actually helps the process. And so we need to do this work to move things along. And then we were very fortunate in the community to get a large grant to think about developing education programs for AI. And it was funded by Future Skills Center. And we partnered with the local Vector Institute, and we published the protocol. And at the heart of this, again, was very much knowledge-based, right? How do we shift knowledge, skills, and attitudes to think about this work? But we also tried to do it in terms of trying to leave behind some evidence around what that might look like. So that project has been going on for a couple of years. And part of what we did was we did a series of scoping reviews as part of this work. And again, very rudimentary, this work was done by one of my PhD students, and it was asking very fundamental questions about how do we do that knowledge creation. So what were the most effective educational approaches? What were the enablers and barriers? What were the outcomes? And again, not rocket science, but sort of fundamental questions that led to the beginning of the thought that maybe there's a continuum of learning that we need to engage in. And I think this is a bit of a useful product, needs to be updated, but still we started to map out, what at various levels, and you could substitute this, I think, for novice and intermediate and expert. What's that journey look like of knowledge, and starting to say, how do we parse this out? What do people need to know? And I think this is going to change. But at least there are some fundamental pieces, like what is AI? What are the various types of models? People need to have that vocabulary. We need to build up our literacy. And so to date, we've trained almost 1,000 leaders and clinicians in various areas. And I think the most important thing that's come out of this is the conversation, what we were talking about earlier. To Tina's point, how do we actually engage people to shape the future? And how did we do it? We made it very problem-based. It's not about the technology, it's about what problems are you trying to solve and the right fit of that technology. And then in 2024, how many people have seen this review? It's an amazing piece of work, really. A BIMI guide that came out to do a bit of a map. And it was done in 18 weeks. It was a rapid review. And at this same time, it follows a lot of the very fundamentals of scoping review. A couple of things just to point out, where the studies are coming from maps exactly to where Martin shows the data sits. And so that's not a surprise, but in terms of questions we should be asking, I think this map actually generates a whole lot of questions around equity, around where the knowledge sits. And Martin gave us a nice example about how we might think about generalizability. And then on the left-hand side, again, another view of some data you've already seen today, but this is the publication. It looks like an area under the curve chart, but this is actually how many publications have come out in the last couple of years. And so the bulk of this work is in the last 2 or 3 years. You might have some guesses about why. And the light blue are perspectives and commentaries. The dark blue, I think, are studies that are starting to go a little bit deeper. So I think we're starting to amass some of that data. And then we've already heard today about a number of areas where those studies are actually accruing in terms of admissions, in terms of areas around assessment, simulation, so there's starting to be a bit of a framework to understand this. And the thing that the BIMI review does, which I think is very useful, is starts to give us some vocabulary about how to report and how to talk about this from a medical education perspective. So it talks about this facets framework, creates a series of categories around forms and AI use cases, context, so on. So one of the things that I think we can do as a community is start to adapt these tools and use these tools so that we can have common conversation and at least build some vocabulary as things change rapidly. The other thing that's very prominent in this review is the vocabulary around equity and creating a classification for how do we think about equity and AI. And it's becoming a dominant conversation for us. I'll point out that one of the things that's really emerged is the theme of compassion, and I was happy to see that they're represented in all of this work. So again, another framework, another way to think about this, and I think this again helps to move our work forward. And so before that work came out, this was we were quite interested coming out of the FSC work, out of the Future Skills Center work around the question around what's the role of AI in building equity. And so we asked this scoping review question, what are the opportunities and challenges of advancing health equity in AI through education and responsible implementation? And again, a lot of this work is being conducted in North America and in Europe. At the time, we had 11 articles from the peer-reviewed literature and the gray literature. We're just updating this now. But here were the competencies that came out of that work. And I think this helps to set and answer the question around how do we start to engage and do some of this education. So one of the dominant things that came out was how do you demonstrate compassion using AI? And go back to our friend Rodrigo, in his work as a conductor, he had a hard time sort of negotiating that. And I think this is something a lot of clinicians are struggling with, is how do we negotiate this conversation? How do we appraise the outputs and the biases critically? How do we understand the applications, the data, visualization, governance? How do we communicate the functions? How do we demonstrate this continuous learning mindset? And so out of this, we have a recommendation about from the micro, meso, and macro levels around how to engage in some of this work. And we tend to focus a little bit on the individual and interpersonal, maybe a little bit on the organizational. there's not been so much around the systems level piece and from the medical education perspective. But Caitlin Gillen engaged in that particular question for her PhD work, and thinking about scope of practice and organizational questions for AI. I think her first paper is just about to come out from the thesis. But this was the question: when faced with AI as a disruptive technology, how do health professional associations engage in sense making and legitimization of change to support their members? And I'm happy to say that there was theory behind this, so that you can, maybe that was the little dot paper. But Caitlin will use normalization process theory to elevate this conversation and say what's happening at the organizational level, what's happening at the scope of practice level. And it depends on the organization, but the vocabulary that we're building to talk about this, I think, is quite important. So I'll end here. My list of questions isn't as long as yours, but I thought maybe a couple of things to focus on, and I think we're in agreement about have our research questions fundamentally changed. The ones in gray I borrowed from Walter Tavares, who recently wrote a commentary about the future of CPD as part of a journal article, a special issue in C.E.T.S. And I think these questions actually, with a little bit of altering, are quite useful. You know, what new conceptual shifts or ideas will advance our understanding of AI in medical education? I think that will be a useful question. And something that Walter is very keen on in this discourse is, what should we stop doing? What isn't useful anymore? Are there some things that, besides commentaries, are there some things that we should stop doing? You know, how will our professional identity change as medical educators? Will it change? Maybe. Should it change? Mohammed Mandami has a good line about clinicians. He says, you know, AI is not going to replace clinicians. It's just going to replace the ones who don't use AI. And that may be something we need to think about as a community. Will we stay relevant if we don't start to figure out how to integrate these tools? This issue's come up already. We've done a little bit of work in the area of patients and what role do patients play in helping to drive this agenda. This is a really important question, I think, of how do we engage in patients. And we also wrote a paper, a qualitative paper, asking the questions to patients: what should your providers know about AI? And so I think this will drive some of the conversation, drive some of the context. How do we build trust and compassion? And then, you know, what are the adaptive capabilities of an AI education? And I'm going to leave that to Maria and Nikki to fight about, because they seem to be quite good at it already. So I'll end there to say this changes more than anything. Well, maybe. What should the question be? Thank you.
Alaa should be popping up on the screen. Oh, there's Alaa. Right. Christian, can we make spotlight Alaa, please? Welcome.
Well, can you hear me? I can see anyone, so I'm assuming everyone can hear me.
We can hear you, Alaa. I think we're just seeing your
Slides?
not your slides, so we're seeing your oh, there we go. We have no, we've lost you. Yep, we're good. Thanks, Alaa.
Perfect. Well, I want to say it's such a pleasure and honor to be, first of all, one of the panelists and follow Dr. David Wiljer and be here at the Wilson Center community. It's so dear to my heart, and I'm really glad to be on this topic today. I had, so this week is a week called Stanford Health, which that's why I wasn't able to be in person, where we are having a series of conferences around responsible AI. And one of the questions that came yesterday about ChatGPT, and I thought it's interesting to bring it to this community, One of the attendees asked, in 5 years, 35% of physicians will retire, while the acceptance rate in the US medical school is only 5%. I assume something close to that. In the Canadian medical schools, can ChatGPT help address this admission rate problem? So I thought it might be interesting for this community to think about. I like to start with the context that I'm so grateful for my experience being grounded and trained at the Wilson Center. It has shaped the lens of how I learn, how I ask questions. And it has really been such a powerful way for me to bring new lens and ask different types of questions in the space I'm in. So moving to Stanford, just what people, my mentors would know that I have so many interests and I intersected so many different labs, but I do multidisciplinary research, sitting primarily at the ethics and policy component, as well as clinical evaluation of AI algorithms. My learning objective today, and I'm going to diverge from talking about, what needs to go into the curriculum to saying stop, what we need to think about, and what are the blind spots about what we are learning from AI deployment that we really need to think about before thinking of what is the content that needs to go into curriculums. So my key takeaway for you today is we need really to start asking the right questions. We need to be asking what expertise and competencies we want our health professionals to possess in the next 5 to 10 years. What are the effective ways of incorporating this? I think there has been a lot of focus, as we have seen from Martin and Dr. Wiljer, around integration into curriculum, but also what is about the practical experience during residency and training. So all of that is unasked questions. So my motivation starting at Stanford to study data ethics, and that really stems from the work I did at the Wilson Center as well, is understanding why there's problems and ethical issues in the development of AI algorithms. And we know that the main problems of why we lag behind is because we have ethical, safety, and cultural practices that lead to ethical problems, that lead to AI that are biased, that really lead to disparities. And so we're always going in that cyclical loop. So I think limited access to high quality health data set is a major barrier. I heard Martin's comment on public data sets. And I have to say, I'm going to try to hopefully show that there's some effort to kind of improve that, but there's definitely a need for more. So the framework on which my work has operated is, let's look at the pipeline of how data flows. Let's look at where bias can enter and where are areas where we need to study. And I focus primarily on understanding what happens, because as Mahan has mentioned at the beginning, we should be treating data as a data sovereignty, not as an ownership. However, most health organizations treat data as an ownership. And so there is a lot of tension, and my goal was to understand what is that pathway, what blocks the flow of data. So when I arrived at Stanford Amy Center, there was a collaboration with the Gordon and Betty Moore Foundation, a nonprofit, and it received a large funding. The center received a large funding to address 2 main components. So the Amy Center is really huge in parts of its mission around enhancing shared access to data, open data set, and primarily it goes under careful curation, privacy office, and people at Stanford, clinicians who have led the effort, is trying to say, let's make this public for people to build algorithms. Of course, this is not sufficient, and the Stanford population is not representative as well of the bigger population. And so there is always the questions we always tend to ask. But the main component for this grant was, can we look at the motivations or the barriers that affect organizations' behavior? What makes some organizations willing to share, like Stanford, and what are other factors that make organizations resistant to share? And the other component of what really defines high quality data sets. So we were talking all about, I have heard from the discussion and conversations, issues around the quality of the data and how do we ensure labels are correct and all of that. And so in this study, it's co-led by my colleague, Madlena, who looked at, from the user data developers perspective and clinicians, what are the optimal data set characteristics. And that have informed us to kind of curate and evaluate the top databases, medical databases for AI research, and compose that in the Amy Dataset Index, which is open. So I was really excited to embark on organizational factors because I came from research that was conducting at the patient level and at the provider level, and I was really frustrated or curious to understand why some organizations are resistant to sharing as I evaluated the data. So I'm not going to go into the depth of it because I want to get into the discussion, but the main component of what really excited me about this is I have designed a multi-case study where I looked at organizations across the academic, government, nonprofit, and industry, because I wanted to understand what are the dynamics that are influencing organizations to either share and not share. The study was focused on the C-suite, so most of the people we have interviewed had data sharing role responsibilities, and so they were having the perspective of they either making decisions about data sharing or they are on the regulatory and clinical data infrastructure component. So gladly, this paper was published in JAMA Network Open later last year, and the main components of what we looked at is, first of all, I'm here highlighting the leadership roles because these roles are different titles that entitle different responsibilities. And so this is part of the organizational problem of that there isn't a job role of a chief medical data scientist that will carry on the same responsibilities. So across institutions. Now, I think it's important to recognize that most of our sampling came from academia and nonprofit and really very little from industry, because you can imagine how industry, there was a lot of resistance to get that. And we are really inspired to know of cases from the government. So this is the most interesting and component part, and we really thought about that so much. But the main factor that as we analyzed the data, that we found was explaining the behavior was if the organizational mission is aligned, if the data sharing priority is aligned with the organization mission, this is when the organization is going to build into the capabilities of its organization to share the data and make it publicly accessible. I'm going to share an example. But if this alignment does not exist, no matter how much of the capability you have, you're not going to be able to share data. And so we're saying motivation precedes capabilities, but capabilities is essential to be able to share data. This quote highlights, that, for example, you can see collaborations happening between government entities and academic institutions, and that's because they ultimately have the same values and shared values around public good and promoting scientific discovery. So it here says for academia, the calculation is even more intense because we are meant to be a neutral entity that evaluates science and medicine in a way that isn't biased by profit. Put that aside, the principles of our mission and nonprofit status, I think, really do guide us here. That's why we put governance in place that prioritize ethics over profit. So the theme of ethics over profit is a big driver of how tension happens in the health AI ecosystem. And the main barriers for academic institutions and government to really build collaborations with industry would not be surprising is reputation. Reputation and financial liability, legal liability, all of these consequences are huge barriers that organizations think about carefully before really releasing data. Data is associated with a number of risks, specifically data re-identification, and a number of factors that makes it really risky for organizations to invest in. And we found that what was very interesting is the motivation for data sharing could be manipulated or could be shifted. So you can increase motivation or decrease motivation. Or if you think about it in terms of the alignment, you can make that alignment happen if you know what is the right incentive for the organization you're tackling. And we found that organizations are relatively going to share, if it's academic or government, is they want to promote scientific discovery. But for other organizations that, such as health systems, for example, that are not affiliated with medical centers, or even those affiliated, maybe reputation. They want to have their name as the releasing of the data of large data sets. And other, of course, there's the data monetization, which is the raises ethical questions around how clinical data might be sold or in a transaction monetized for the purpose of AI development. So I wanted to share this code because this code, the context of it is it's a data informatics expert from a government, and it speaks to health equity and incentivization. So a big component of what people have been focused on is we know that health centers that are not academic institutions or not Ivy Tower League struggle to really be able to have the data infrastructure and capability. But what we have seen from COVID-19 is that there is government or funding initiatives that's able actually to shift the dynamics and capabilities and infrastructure. And the context is the NCATS data set consortium, this brought more than 70 institutions together. The main condition for this consortium to operate was that the centers with the high infrastructure and resources and expertise will be lending hands in terms of building the smaller centers and community hospitals to have that infrastructure. And so this was a quote from a data informatics expert who was talking about the massive inequities in infrastructure. And so she says, I don't think that there are massive differences between sites. There are some sites that have tons of informatics expertise, lots of faculty, lots of staff, lots of computing power. And for the most part, those sites had no problem getting up and running on, at least from a technical perspective. Then there were sites that really wanted to participate in, but they hadn't participated in anything like this before. So the Amy Center, Stanford, Harvard, there's always that machine of producing that for research, but that component is really lacking in places where we really need to build that infrastructure for AI to come into rural and smaller community hospitals. So the main takeaway was looking at, if you could look around the organizations we interviewed. So I interviewed over 18 organizations, and we were starting to see that there's a pattern of, from organizational network research, there's some organizations that are playing the role of being energizers and be able to promote, for example, increased data sharing. So nonprofits, for example, such as Nightingale or other things, that they take the data and they just release it to the open public. There's people who act as brokers, data brokers, and that can be financial or that can be, private or nonprofit. And there is other components of challengers who are holding onto the data. And I'm kind of coming to the main component of what really drives, at the end of the day, the decision to share, not to share in terms of alignment is how can you balance the facilitators and barriers to data sharing. So we know the governance, access to data, and all of these are common issues. And so if you can have your facilitators trump your barriers, this is when potentially you are going to share data. The key takeaway from this study was that clinical data flow is not flowing because there is tension and competition across the clinical data pipeline, where we're not really driven on a one mission from patient to take the protecting patient data and really building algorithms, but there is tension between academic institutions holding onto the data as it's a data ownership and afraid for reputation and other risks. And then there's the private sector, for example, who you can see in the colored boxes, they have a lower reputation, but they also are less risk averse. So they have risk mitigation strategies to data sharing and data collection, but they're not as bureaucratic in terms of governance as academic and government entities. And so my conclusion has been organizational readiness stems from motivation and capabilities, and that leads to the point of, are we training people to be organizational leaders that really are able to spark that culture that promotes, like AI innovation. AI has risks, and so a big component of how this work is translating is what do we need to educate executives and people in healthcare institutions around the priorities and how they think about that. And it's important to recognize that most of the high quality data sets that are being used are built by physicians, but it's a labor intensive work, and many people are not able to do that. And so I think we need to factor, if we want to build AI champions in clinical care and research, we need to think about what are the incentives for them to do that in terms of time and resources and credit. I'm going to end on this. Someone said it really eloquently. So we keep saying data for public good, but this person said, I'm all for the public good. I love the public good, but I think we need to define public good in ways that are sharper than order for someone. Like if you have specific costs attached to making the data available, you're unlikely to share if the organization invests a lot. And so you can't just say believe in public good, capital P and capital G. That's not going to work. And that's really not working. So there is no free lunch. So this wraps one of the components around understanding at the system level, what are the organizational barriers? If we move on from that, we started looking at clinical evaluation of algorithms. And what clinical evaluation of algorithms look like is we have algorithms that are coming into the pipeline of implementation. And as a team at the Stanford Data Health Science team, we we conduct evaluation at the different component, at different stages to assess whether these algorithms should go in or not. What we have been learning is a lot of questions and a lot of gaps and blind spots that make us have reconsiderations for what should we really be educating and training clinical fellows on. So the process is called FIRM. It's called Fair, Usable, Reliable AI Models. I have the reference in the chat. It's in preprint right now. But the main component is there is always going to be tension between, like any AI guided work need to be built around the model, and that model can influence policy and can influence action. And so we need to test that, and we need to have a process that allow us to really vet what is the value of that model in order to drive either policy changes at the hospital level or action in terms of implementation. The FIRM assessment is composed of 3 stages. We're not at the 3rd stage yet, but we have much of the focus has been on the ethical considerations, the business case of how we actually assess and ask the question of what and why are we implementing an algorithm. And that has revealed a lot of ethical and financial questions and tension around decision-making around whether we should implement algorithms that would be useful in clinical care. This slide is not meant to really kind of, it's busy, but I think the main component of it is this illustrates one of the use cases. And this is one of the use cases for peripheral artery disease detection. And the main complexity comes in understanding the workflow, and how you're changing the workflow when you're embedding AI is the key secret sauce into how we were able to kind of understand whether this algorithm is likely to work or not. I quote that from an interview that I conducted with one of the clinical nurse operation leads when we were trying to implement a sepsis algorithm. And it really drove me to think around, we also need to think about how we study team dynamics and culture and tension. So this nurse operational lead was saying, I would say that there would be implications for advanced practice provider, as well as with like our doctors, because I think once that alert gets fired, the responsibility of the nurse is to advocate and notify. Now, when they are making that call and there isn't a lot of trust or certainty in that alert coming to their attention, and that predictive model really being both specific and sensitive, even enough as we want it to be, I would say teamwork deterioration, it can negatively influence the perception of our provider and the competence of our nursing staff. And we really did not, some of the decisions around moving with translation was really around the tension, around the tension among staff themselves in order to be able to feel that, can we navigate the work dynamics and tension if there's false positives, how the team dynamics is going to change. And there is a lot of tension already within the clinical teams. And so it raises another question of, do we need to really focus on understanding and improving professional and empathy culture among the teams themselves and cohesion before we really think about how we bring AI into that? This component, speaking of evaluation, we really have, I think Martin made a really great point around, evaluation of algorithms and the data that's coming in, and with the all kind of like open door of ChatGPT. ChatGPT or large language model has become everyone's business. But this work was led by the original study was led by my collaborators at the Amy Center, where they evaluated a large language model. And my review was meant to illustrate what are the questions that a clinical expert who is not really building the model need to ask. And the main component of this diagram flow is to say that clinicians need to ask questions around what are the trade-offs between the open and closed models. They need to ask questions around how the model performance improve if we give it in context data, for example. So we talked about, we don't want data scraped from the internet, but sometimes you can have ChatGPT-4, and with some in-context learning, it can really outperform other models. I think the main component I really wanted to highlight is we talk a lot about or hold AI to such a high standard of perfectionism. The question should not be about whether AI is perfect or whether AI is going to be embedded in the workflow to have I would say, like unreasonable expectations. But the question becomes, if AI is embedded in workflow, what is the impact in terms of clinical benefit, and what is the risk of harm? And what was so interesting in the study is when they compared the risk of harm if radiologist or in the summarization report were to go wrong, even if the model makes a mistake, the best model performed better than had less error rate compared to the medical experts. And so I think that raises a bigger question of, we really need to be asking the right question around, if we're training clinicians to really assess models, they need to be asking the right question, how this model is compared to how we perform right now, who is the medical experts. And I think those are key lessons that we're starting to kind of learn as we think of how we integrate language models clinically. I want to end on ethics. So I did a lot of my work in ethics, and this study was eye-opening in terms of, I have conducted ethical interviews, but this study was meant to examine the NIH ethical values, and I recognize, are we at
Alaa, I'm sorry to interrupt you. I'm just aware of the time that we have to vacate the room. So maybe we could save this lesson for the Q&A, if that's all right.
Yeah, sure.
Yeah, I'm sorry to cut you short, but we're running a little over time. My apologies.
Oh, that's a problem.
Sorry about that, folks. Sometimes these things happen. I forget how tricky sometimes in-person events can be. So I'd invite David and Martin back to the stage, and I'd like to thank both Alaa and David for a wonderful presentation. And now we have some time, a little bit of time for questions, and for Alaa or for David and Martin as a group, or if you want to address a question to one of them or all three of them, you're welcome to do so. The question that I have for everybody, yes, that's okay. The question that I have for all three of you is that Alaa talked a lot about the alignment between social mission and the need for data sharing, and whether that alignment has to be present. As far as I can tell, and Paula can back me up on this from her work with organizations, is that almost all institutions say that there's a social accountability to share, or social accountability to evaluate their work, to share data, but very few do. What do you think that's, what do we do with that information? How do we get around that issue?
I'll start for a couple of thoughts here. I think in the world of AI, where we're at now, we have to recognize that there is a lot of competition, and there is a lot of trying to get to be first past the post. And that is a bit problematic when we talk about the social accountability piece, is there's what is actually valued in the organization to be first and to be able to make some discoveries. The second piece that I think about here is, I do think that this is where partly the engagement with patients, people with lived experience in the public, really can come to play here. They, at least in our country, they experience care across a number of domains. And so thinking about how their data is essentially sometimes being hoarded, is not being used for the greater good. I think that's a conversation that people want to engage in, they're ready to engage in. And then how do we do that safely and with some accountability? So I think we have misaligned incentives, at least in our country, that make it difficult, and we have to have an open conversation around it.
Martin, in Denmark, I noticed you referred to many many registries of clinical data that you're able to leverage. Can you expand a little bit on how they've been established and how you've been able to use them to advance the program of work you're doing?
Yeah. So since I think 1978, when you're born in Denmark, you get like a stamp, a virtual stamp at least, with a birth date and your social security number, and that number is being used to tie in all sorts of types of information. So your grades in high school are there, socioeconomic data, the number of times you went to see your TP, the diagnosis codes, so the ICD-10 diagnosis codes are put in there, and you can draw them out, and that's registry data, and obviously you often would like to combine that with other sources or types of data, and that's when it can be a bit tricky for us. So learner data is a bit more protected in our context than patient data is. Yeah, and that may vary from context to context, but being able to have to tie a lot of data to this identifier is key, at least for us to be able to reach these massive data sets. But we too experience problems when we ask, for example, for data from the universities because they're afraid of handing them over. And I think it's from an ethical point of view, it's always difficult to justify that you're not willing to provide data that may be able to improve training or practice in the future. So it's just, for me, I can't understand the counter arguments. Yeah.
Mm-hmm.
I think I would just add that there's some organizations that are a little bit far ahead. So the Genomic Health the Global Health for Genomic Health that's actually located in the Mars building, they have actually been working for the past number of years on how they promote genomic data sharing across institutions. And when we interviewed them, they really had, a lot of tools and agreements to help, like people and clinicians if they want to exchange data, and that would be helpful to facilitate that. But the other component I agree is that collection of data is hard, but also there's questions around how much of the data can be scrapped out in terms of de-identification and what makes it useful. And so many of the regulatory perspective is this data needs to lose a lot of it is beneficial data component in order for us to be able to release. Is it worth for us to invest the time and the process to do that? And the other component I would say is there is increasingly, like government funding is moving, at least in the US, towards consortium of data to drive organizations to be contributing to a one pool. And for MEDRIC, for example, for COVID-19, that has shown to be very helpful.
David,
Maybe also be technologies that we are overlooking because we are so siloed as we are. So this has been a problem that's been addressed in data science as well, where solutions such as federated learning answer many of these questions, so that you don't pull out the data to train models, but you are able to train a model locally, and then you transfer the model, but not the data. And then you use that to train your model across multiple different contexts. Or the use of digital twins, where you make a representation in the vector space of a certain individual. Instead of exporting the individual's data, you export a twin that has the same vector representation. So there are some other techniques that are being developed that I think, could be looking into.
Thank you. And for those of you who were wondering, the words David didn't use were COVID-19 and pandemic, I think, in his presentation.
How'd you know?
Yeah, well,
No, ChatGPT.
and ChatGPT. Listen, I'm sorry we had to cut short the conversation, but it's great that the conversation wants to continue. And as you've heard from our panelists and from the other events that are happening, this, we're all in this at this point. But we're so grateful to Martin, David, and Alaa for sharing their expertise and wisdom with us and inspiring, I think, many interesting questions and conversations that I'm sure going to continue. So thank you all for joining us. It is 12 o'clock, so please enjoy the rest of this beautiful day. And I'm sure our panelists will stick around for a little bit to chat if you are interested. So thank you and take care.